Hey guys, I hope you can hear me. Welcome to this YouTube stream. This is our first anatomy lecture. If you guys have any comments regarding the stream itself, stream quality, if you can't hear me clearly either, just message in the chat. I can see that here, and the team can see it as well. So we'll try and improve that. So yeah, welcome. I hope you guys have enjoyed the first week of the semester. I'm sure it's been busy. Um, but hopefully it's been enjoyable. Hopefully you're getting stuck in with studying, and hopefully learnt from the MIMSA semester guidelines talk, which was last weekend, about how to study all your subjects. So this is the first in this anatomy series. So the way these series work is that or the lecturer will go through content based on what you guys have been taught in the week previous to this lecture. So as you can see, I'm going to go through general arthrology, and then I'm going to go through the upper extremity joints and also some of the muscles as well. And then next week will be the remainder of the muscles, and we will basically follow the same syllabus as you do in the seminars and lectures. So I'm going to just kind of go through the outline of how the lecture will look. So this is the lecture format. You can see I'm going to just give you a bit of information about how to study for anatomy, where to study from. It'll be a bit of recap from the semester guidelines, but a bit more detail. And then I'll jump into all of these different sections you can see here. You can see I'll stop at arm muscles, so I won't explain anything lower than the elbow. As I said this before, this will be covered by the lecturer next week. So in terms of the learning outcomes, exam date bookings, this is really a bit more, this slide is a bit more relevant to second semester. But exam day bookings, you don't need to know this for anatomy now, but you will need to for biophysics. So the team asked me to just kind of say a few words about exam booking. So on the information system, there's a tab you can type in examinations, and you'll see there's nothing there at the moment. Roughly about halfway point in the semester, usually in November, the biophysics exam dates will be available to book, and it's basically the system is all online, all on the information system. That's how you book your exams. There'll be a set of dates posted, and it'll be up to you based on when you book those dates. So they'll say, for example, there's a date in the first week, or let's say the 6th of January, for example, and the date is available to book on this Saturday at 5 p.m. It's usually at 5 p.m. So just pay attention to what it says. And on that day, on that time, you'll be able to book. You'll be able to click to reserve that slot, and there'll be a maximum capacity of students available to book for a particular date. So sometimes it can be a bit competitive. So it's important to have good internet connection, and to kind of best advice I can give is to have a clock, digital clock, an accurate digital clock, and as soon as it goes 5 p.m., just start clicking. Yeah, okay, that's exam booking. So anyway, back to anatomy. In terms of weekly timetables, the best thing I would say for this semester is to focus on your biophysics, on all of your subjects as a whole. But for anatomy, it's going to be difficult to keep up because there's a lot of content being covered at a short space of time. So every week you're covering a lot of content. So please, please try and keep up. The best advice we can give is just to keep up. And the best way to do that is to have the correct materials. So for this part of this lecture and this part of the semester, the first part of the semester, the book to use is The Anatomy of the Locomotor System. And this white book is available from the campus bookstore or the library. Now, unfortunately, it's not available on PDF, but I spoke to the head of the anatomy department yesterday, and he said that it shouldn't matter too much because the lectures which are provided to you guys are fully narrated, and there are enough study materials which have been uploaded into the information system, so that you don't actually need the book if you are not here in Brno. If you are in Brno, the best advice that I would recommend, just get a copy of this book, get a hold of this book, because everything they teach comes from these white books. In addition to the white book, which is your guide when it comes to finding the accurate information you need, so in addition to that white book, I would recommend an atlas. So an anatomy atlas, you can see I've got one here. This is the book. This is the book I bought, the first book I bought before I came here, and I still use it. You can use this one. This is Netter's, very good book, or you can use other atlases available. There's a range. So Sabota is another good atlas. But whichever you choose, make sure you stick to it, as you'll need this atlas throughout the entire year. And then there are other materials. You can use flashcards. So there's some apps you can use. One application is called Anki. It's quite good for flashcards for anatomy. You can find Gray's Anatomy. There's a lot of sources online, YouTube videos, and things like this. But at the end of the day, as long as you're disciplined with your your time management, and you stick to the white book as your go-to text, then you should be fine. Everything you'll need to know for anatomy is available in these books. So I'm not going to go through how to answer an oral question. This will be more for next semester. But one thing I would like to say is that you guys will have USMLE style tests. So it's USMLE style tests. They're not USMLE exams. They are papers. They are multiple choice question papers, which have been written in the style of USMLE exams. Just for those of you who aren't aware, these are the licensing exams to practice medicine in the United States. The first part of which contains a section on anatomy. So the way the tests are made or created, the reason that they're here is to give you an incentive to do well, to achieve high grades, high marks in these tests, of which there are 3 in the year. And if you are consistently performing well in all 3, you will be exempt from sitting the final anatomy exam. And if you've spoken to any upper year student, you'll know that it's a big exam. So my personal advice is do what you have to do to basically avoid the final exam. I just saw a question. Yes, the stream will be uploaded onto this platform, MIMSA Lectures platform, to watch afterwards. Okay, so yeah, one other thing. Yeah, sorry, the material I'm using is all from this one book. Okay. So I've pretty much jumped ahead. I've pretty much summarized all of this stuff for you guys. But as you can see, the first box is more about kind of gathering your thoughts, collecting the correct material, and finding out what works best for you. There are many ways of studying anatomy. Some people prefer to write notes. Some people are very visual learners. They need diagrams and they need videos and colorful images. Some people like speaking out aloud. Whichever technique works best for you is the one you should use. So I would try, at this stage, I would try different techniques, different methods. The one common thing I would say is the one thing just to kind of bear in mind is that it will take a while to memorize, to learn the content. There's a lot of content to be going through, so don't be put off by that. It takes a time. It takes a while, but that's just how anatomy is. You can see from the middle box, it's just about which materials to use. And then the last box is just testing and explaining and revising and recapping, because the only way you're going to remember all this information and, more importantly, retain it for the first USMLE style test, which is happening this semester, the only way you can do that is by constantly revisiting this content. So when it comes to muscles, bones, joints, it's quite. I wouldn't say it's the most interesting and engaging part of anatomy. There are just a lot of facts you have to memorize. So if you can keep revisiting this content, you'll make your life a lot easier when it comes to exam time, because you'll just have to end up relearning the content otherwise. So keep revisiting, keep recapping. Okay, so let's talk about the first section. So general arthrology. So what general arthrology is the science of how we classify joints. Okay, so how we classify all of the joints in the body, as opposed to special arthrology, which goes into detail about each specific joint. So we're not going to be talking about special arthrology of the whole body. In a bit, we're going to talk about the special arthrology of the upper extremity. So now back to general arthrology. There are 2 main types of joints we have in the body. We have synarthrosis and we have diarthrosis. So synarthrosis, as you can see, these are joint connections which use connective tissue. That's the most important thing. They use connective tissue which anchor two bones to each other. Very minimal movement as opposed to the synovial joints. Synovial joints, also called diarthroses. And there are three different subclassifications of synarthrosis. So just one thing I just wanted to highlight. This part of the word here, arth, A-R-T-H, refers to joint. Okay, so arthrology is the study of joints. Synarthrosis means the connections of the joints. So you can see here we have the first classification, which is syndesmosis. So a syndesmosis means that the connective tissue between the bones is fibrous. Okay, fibrous connective tissue. And more often than not, they're ligaments. So ligaments holding together a structure. And some examples of syndesmosis in the body are skull sutures. So these are bones which are bound together and are connected by fibrous connective tissue, which has over time ossified. And another noteworthy point is a gomphosis. A gomphosis is a special type of joint. It is itself a syndesmosis, but it's specific in that a gomphosis joints are found in the alveolar regions. So what anchors the teeth to the mandible or the maxilla, this is the type of joint I'm talking about. So that's what a gomphosis is. So syndesmosis is the first type of synarthrosis, where the bones are held together by fibrous connective tissue. The second one is a synchondrosis. So this involves cartilage. So the structure, the connective tissue type between the bones is not fibrous, it's cartilaginous. So cartilage is between the two bones. And the third type is a synostosis. Synostosis simply means there is bony material between the two bones themselves. Okay, so back to synchondrosis, you can see it's associated with limited range of movement, and a synostosis can be either physiological or pathological. So one example I just mentioned of a physiological synostosis, so something that happens so normally occurring in the body, is the sutures of the neurocranium and the splanchnicranium. So the skull sutures, the gaps between the individual skull bones. At birth, they're connected by cartilaginous tissue, connective tissue, and also fibrous connective tissue, and over time they ossify and become synostoses. Okay, so diarthrosis is the second type. So just a quick recap, we talked about joints. Generally, we have synarthrosis and we have diarthrosis. So synarthrosis, we have syndesmosis, synostosis, synchondrosis, and now we have the diarthrosis joints. So it's completely different. And these are called synovial joints. Now you'll notice in my slides, I've written, not all of the time, but most of the time I've written the English and the Latin. I get asked this question quite a lot. And the question is, do I need to learn Latin? The answer is no, you don't have to learn Latin. I understand it can be quite difficult if you're not familiar with the words. But I promise as the weeks go on, as you learn more Latin in your medical terminology classes, you will become more familiar, you'll become more used to seeing and reading the Latin. And by the end of the year, when it comes to your final anatomy exam, you'll understand these words. For example, articulatio synovialis, you'll understand that quite quickly without needing to think. That just means synovial joint or synovial articulation. Okay, so what are they? So these are movable joints. This is the most important thing to kind of discern between synarthrosis and diarthrosis. They are movable joints, which will connect at articulation surfaces. And there are different parts of the diarthrosis we need to discuss. So joint facets, the capsule itself, cavity, and then accessory apparatus. So I'm going to just talk about each in turn quite briefly. So joint facets. So the joint facets themselves are the areas of the bone which are in connection, which are forming the joint, the diarthrosis itself. So which area of the bone is contributing to the joint? So that there is usually an articular head, articular fossa, and there is articular cartilage. So the fossa is just a pit. Fossa just means a shallow pit. And the second thing was the joint capsule. So a joint capsule is made up of two layers. We have an external fibrous layer and an internal synovial layer. So this is, just remember, this is a hallmark for all diarthrosis or synovial joints. Just think of the shoulder joint, think of the elbow joint. We're going to talk about some in more detail, but all of these joints which are diarthrosis conform to these contain these four parts. So joint capsule is the second one. Third and the fourth. So joint cavity is the third. So this is the space. Okay, this is the space within the joint itself, and it contains synovial fluid. And the joint, the membranes themselves, so the joint capsule is richly innervated and has its own blood supply. So this is what replaces the synovial fluid over time. And the final thing, the last thing to remember about diarthrosis is that we have these accessory joint components. So ligaments are fibrous bands of tissue which connect bones together, and they support the joint itself, and they prevent things like dislocation. You can have capsular, intracapsular, extracapsular. These are different classifications based on where these ligaments are found in relation to the joint capsules. So if you think back to the joint capsules, we had two different types. We had a synovial and a fibrous capsule, and these words just describe the position of these ligaments in relation to these different capsules. Labra. So labrum is a widening at the margins of the joint. This is obviously general arthrology, so not all diarthrosis and not all synovial joints will have all of these accessory apparatus, but some do, and I'll talk about which ones do in a moment. Discs, so discs and menisci. These are cushioning pads. You can imagine them as kind of pads, shock absorbers, which can support quite immense amounts of weight, load bearing. Synovial bursae, these are pockets, small pockets, which again provide some sort of cushioning and decrease friction. And then finally we have some muscles as well. So there's a lot of muscles as well, which will anchor the joint capsule and which will support the joint itself and also prevent dislocation. Okay, so classifications. There's few different ways of classifying joints. So the first way of classifying them is according to the number of articular surfaces. So if we have two articular surfaces, it's called a simple joint. If we have more than two, it's called a composite or a compound joint. Second way is a bit more complex. This is the shape of the articular surfaces. So just recap, when I mean articular surface, I mean, for example, this surface which is in contact with another bone. So two bones are in contact, but the surface is the specific area on the bone which is in contact with the other bone. So the shape of the articular surface is also of importance, and these are the classifications which I'm just going to run through now, which you can see in the image here. So an uneven joint with sort of irregular surfaces is called, that has its own name, which you do need to remember. It's called an amphiarthrosis. This is very restricted movement. We have flat joints, we have spherical joints, which can further be subcategorized as free or restricted. So I'll give you examples of each. A free spherical joint is the shoulder joint. An arthrodia is so the shoulder joint is an arthrodia type joint. It's a free spherical joint, and what that means is that these spherical joints are also called ball and socket joints. So the free joint means that we have a very shallow capsule. A very shallow socket. Sorry. So that means that there is a very wide range of movement, very easy to dislocate. In contrast, a restricted spherical joint is called an enarthrosis. So the hip joint is a typical example of an enarthrosis. And this means that the socket itself encapsulates the ball a lot tighter. So there is less chance of dislocation. We have ellipsoidal joints, we have cellular joints, and cylindrical joints. Just in case you're kind of confused, all this information is from the White Book. So please have a look at that as well. And cylindrical joints, you can see we have ginglymus. Ginglymus is a specific type of cylindrical joint. And a ginglymus, one example of a ginglymus is the temporomandibular joint. So between the temporal bone of the neurocranium and the mandible. And a wheel joint is another type. And in the book, you'll see it's called a trochoid joint. So just pay attention to that. So these different classifications of joints allow different degrees and ranges of movement based on which part of the body we're concerned with in terms of what movement we need to try and perform. And the last one, I forgot trochlear joint is the last one. So we talked about, just to recap, we talked about the number of articular surfaces. That's one way of classifying joints in general. So every joint can be classified as either a simple joint or a composite joint. That's one way. We can also classify joints by the shape of the articular surface, of which this is what we just talked about. And the third type of classification is the type or the range of movement of the joint. So we can have minimal movement, or sliding movement, rotational movement. The rotational movements can be based on a varying number of axes. So a monoaxial joint means that we just have one axis. So for example, flexion and extension in a joint is monoaxial. Biaxial means that we have, for example, flexion, extension, but also pronation and supination. And I hope you're aware of these terms. These are anatomical directions. So I'm not going to, this lecture won't cover that, but please, if you aren't aware of these anatomical directions, please go and study these. So then, multi-axial joints. Typical example of a multi-axial joint is the shoulder joint. So we can perform abduction, adduction, rotation, internal and external, flexion, extension, elevation, depression. So if there are 3 or more axes of movement, it's called a multi-axial joint. Okay. So this is how to answer any joint question. So this is more relevant for the second semester, but this is how you answer if you get a joint question in your final oral exam. I know it's a very long way away, but I'm just including this very quickly, and this is something you can revisit next semester. This is the template. So you first talk about the name of the joint. It makes no difference whether you say you give your answer in English or in Latin. Next thing to do is you list the bones involved, mention the names of the articular surfaces, so the head and the fossa, as I previously mentioned. Then you talk about the type of joint, so the number of articular surfaces, the shapes, and the type of movement. So everything we've just discussed about classification. Finally, the attachment of the joint capsule, and then the accessory joint structures and features. So if you just kind of take a second to just look at this slide, because every joint I'm about to discuss will be I'll use this template basically for every single joint. And the degrees of movement, so connections with the upper extremity. We have shoulder girdle joints, which I'll discuss. Then we have the actual shoulder joint itself. So the shoulder girdle joints support the shoulder in relation to the sternum, the clavicle, and the scapula. The shoulder joint itself involves the bones I just mentioned, also the humerus. Then we have the elbow joint, the radio-ulnar joints, radiocarpal joints, and finally the hand joints. These are all the joints I'm going to go through. The 2 largest joints, the most important joints, are the shoulder joint and the elbow joint, by far. Okay, so what I've got is in fact, let me just show you. So I've got something that looks like this for every joint, followed by an image to help you. So this table is taken from a document which I've made and I've uploaded onto the MIMSA Hub. You can access the MIMSA Hub via visiting mimsaonline.com, and you'll see Study Hub at the top. So just visit our website, find Study Hub, and go to first year, and then you'll see anatomy, and then the document is called Joints. So what I've done is, because I found it almost impossible to study joints from the white book directly, just because of how it's written in paragraph form. I just didn't like that. I rearranged the information into these categories. So the same template I showed you in the previous slide is here for every single joint. The joint itself, articular surfaces, what the capsule's like, additional structures, and then types of joint and movement and that kind of thing. And I've done this for every single joint. So you can see here, the first one I'm going to discuss is the sternoclavicular joint. So between the sternum and the clavicle. I'm not going to read out all the information here. I'm just going to talk about the main things because I don't want to waste your time. And this is more of an exercise of you really sitting down and taking the time just to study alongside a picture. So I'm not going to just repeat everything that's on the slide. So you can see here articular capsule. What you need to understand: it's solid and attaches to the margin of the joint itself. You'll see this repeat quite a lot. Additional structures. These are the interesting things about the joint, the unique features of the joint itself. So the sternoclavicular joint, think about where that is, between the sternum, the breastbone, and the clavicle. There is an articular disc. So a disc is present. This is not present in every single joint. This is something which is unique for the sternoclavicular joint and a couple of other joints. And this is some fibrous cartilage, which is acts as like a cushion. And it separates the joint itself. Ligaments, you can see there are 3 main ligaments involved which anchor the joint together. In terms of the joint type, it is a composite joint. It's a spherical joint, an anarthrosis joint, which some people find hard to believe. I'm sure. I think I found it quite difficult to understand how this joint here is actually a spherical joint, but it is. It does have restricted movement, but it can move in various directions, and you can try this out on yourself. For an image, to make things a little bit clearer, you can see here where the articular disc is on the left hand side. You can see a dissected part, or dissected half. The disc is in the middle, which separates the joint, and you can clearly see the 3 ligaments I mentioned anchoring the joint together. So the second one is the acromioclavicular joint. So the acromion is a process, the acromion process, which is part of the scapula, and the clavicle, as we mentioned before, same joint involved. So this is now on the other end, the other side of the clavicle. So the surfaces themselves is the acromial articular surface of the clavicle, and then the articular surface of the acromion. So it's important to get your head around that. So on the clavicle itself, there is an acromial surface. Okay, this is the section of the clavicle, the area of the surface of the clavicle, which connects to the acromion. Okay, that's why it's called acromial surface of the clavicle. You can see here articular discs as well as present, and these 2 very important ligaments, the acromioclavicular and the coracoclavicular ligament. I think the naming of the ligaments and even the joints is quite straightforward. Why do I say straightforward? Well, because when you read the name of the joint or you read a name of a ligament, it's very self-explanatory. It tells you all the information you need to know about where the joint is or where the ligament is. So acromioclavicular or coracoclavicular. Coracoclavicular is between the coracoid process of the scapula and the clavicle. Acromioclavicular, like we said, is between the acromion which is a process of the scapula, and the clavicle. So you instantly know which bones are involved. If you're unfamiliar with these parts of the scapula or any of these bones, please spend a bit of time studying the bones of the upper extremity so you're aware of the different processes on the bones. Because then once you learn the names, then you learn the joints, and the joints become a lot more straightforward because, as you can see, the names are quite long and the names are related directly to the bones. And then you do the muscles. So bones, joints, muscles is the best way to do it. So joint type, you can see here, it's also an anarthrosis. It's a simple joint, and you can see the different ranges of movement as well here. Okay, so just an illustration. This is the acromioclavicular joint. You can see the ligaments are present here, and you can see the relationship to the 2 different bony prominences. Okay, and scapular syndesmosis. So the scapular syndesmosis, this is not really typical joint question to be asked, but syndesmosis is the fibrous connections of the scapula, and these are just ligaments. Okay, so these are just ligaments to remember that you have around the scapula. So pretty much all of these ligaments you'll see supporting the shoulder joint are the scapular syndesmosis. Okay, now let's move on to the shoulder joint. This is the most important one to remember for the final exam. If you were to forget, all of the joints in the body, but remember 5, there are 5 main joints to remember. And when I mean remember, I mean to learn and to memorize, understand in full detail. So by full detail, everything you see here essentially. So the 5 main joints are the shoulder, elbow, the hip, the knee, and the ankle. These are the 5 essential areas, basically, essential joints to remember. So we're going to cover 2 of them today. So shoulder joint, as you can see here. So articular surfaces. The glenoid cavity of the scapula. So this is a surface on the scapula. So I'll show you an image in the next slide. So that is the socket, and the ball is the humeral head, which articulates with it. Capsule itself is very strong, and you can see it's reinforced by ligaments. Additional structures, a glenoid labrum. So the labrum is the deepening of the rim. It's like a rim around the capsule, which is a bit deeper. Okay, adds a bit of depth and a bit of reinforcement to the joint capsule. It makes the capsule a bit more spacious. Ligaments involved: 3 glenohumeral ligaments. Glenohumeral, so that means that they are connecting the glenoid area. The glenoid is the area of the scapula to the humerus. The coracohumeral ligament, which is from the coracoid process of the scapula to the anterior side of the joint capsule, okay, so the front of the joint capsule. And finally, the transverse humeral ligament. Now, this one runs over 2 very important bony parts of the humerus, and these are the tubercles, the greater and the lesser tubercles. So labrum, ligaments involved. Okay, we also have muscles involved. Now, this is quite interesting because the long head of the biceps muscle actually originates not on the humerus, as we'd assume. It originates on the shoulder, on the scapula, sorry. And it originates from the supraglenoid tubercle, and it runs through this shoulder joint, okay, through the joint cavity. And then finally, all of the rotator cuff muscles. So the rotator cuff muscles we'll come to a bit later on this afternoon. Bursae involved. These are these small pockets, small cushions, which are located and usually are located around the entire joint, between the muscles and the fibrous ligaments. The type of joint is a simple joint. It's quite straightforward. Simple because we have 2 bones involved, only 2 bones, so the scapula and the humerus. It's a spherical joint. It's a free spherical joint, so in arthrodia there is triaxial movement. So you can see I've listed all the different types of movement in the shoulder joint. Yeah, okay, so let's have a look at the image in a bit more detail. This is an anterior view of the shoulder joint. The muscles have been removed, and all you can see here are the ligaments and the bursae. So these bluish-green pockets you can see are for reducing friction and for providing mechanical cushioning, or mechanical support to the joint. Yeah, so these images are not from Netters, these are from Gray's Anatomy. But like I said before, all the atlases will have a good image. Okay. This is a dissection view. So you can see here the long head of the biceps tendon is here. This is the humeral head. This is the deltoid muscle. And you can see the humerus is over here. So the joint capsule is here. This is the joint capsule. And this is an arthroscopic view, so with a camera inserted into the shoulder joint. These views aren't important to remember, I just put them in here for interest. But you will actually see this in your dissections, which will happen in January. Okay, so elbow joint. Elbow joint is an interesting one because it's the elbow joint itself is made up of 3 joints: the humeroradial joint, humeroulnar joint, and the proximal radioulnar joint. So you can see here, I've divided up the articular surfaces for each of the 3 joints. The capsule itself is common. So I said there are 3 joints, but the capsule itself encompasses all 3 joints, and the ligaments and additional structures are all related to all of the joints themselves. And in terms of the joint types, I've divided them again. So you can see here the humeroradial joint is a spherical joint, humeroulnar joint is a trochlear, and the trochoid for the proximal radioulnar joint. So again, it's straightforward. You just have to go through articular surface. What are the 2 parts? I think the articular surface and capsule is quite easy. Additional structures is I think the hardest thing to remember, because you have to memorize all of these ligament names, and any labra, bursae, for example. You have bursae in this question, and then the joint type itself is very important to remember, because the classification is what they're really going to test. You need to understand the range and the degree of movement of a specific joint in order to understand the type of joint. So here there are a couple of views of the, this is a medial view. This is a medial view of the elbow. And here we can see the anterior view here. Okay, so again, not really much to talk about except just to memorize the names of the ligaments present. If you're struggling to understand the bony structures themselves, go and take some time, have a look at atlas images, trying to really familiarize yourself with the different parts, the different landmarks of the distal head of the humerus, in addition to the proximal parts of the radius and the ulna, of course. So wrist joints. So I've divided this up into a couple of slides, but the wrist joints are the distal radioulnar joint, so the connection between the radius and the ulna, but obviously in the wrist, so that's why it's called distal, as opposed to proximal, which was part of the elbow joint. And the second one is the radiocarpal joint. So the radius articulates with the carpal bones. So articular surfaces, quite straightforward. For the radiocarpal joint, the articular surfaces you can see are only for the scaphoid, the lunate, and the triquetrium. These are 3 of the carpal bones. Articular capsules, quite straightforward. Margins of the joint capsules. Additional structures, discs are present, and also ligaments as well. So the radiocarpal joint, in fact, the hand and the wrist contains a bunch of ligaments. So it's easy. It's always better to classify them one at a time. Do one joint at a time, because you'll see in a few slides it gets a bit complicated. And the last thing is understanding the type of joint. So for the distal radioulnar joint, it's a composite joint. It's a trochoid monoaxial joint. That just means a type of movement, and you can do pronation and supination in this joint. So pronation, just in case you're unfamiliar, if you think of the anatomical position where your hand is flat and your palm is facing forward, what pronation is rotation, where your palm, P for palm, faces the ground, and if your palm faces the sky, then S for supination. So if you think of those rotations, so palm facing the ground or the plants, I've seen something which is like palm facing the plants, P for plants, that's pronation, and your palm faces the sky, S for sky, that movement is supination. So another way to remember it is internal rotation is pronation, external rotation is supination. That's a bit more complicated. But yeah, just try and get your head around these directions, because they pop up a lot, and you'll need to know them off the tip of your tongue for the muscles. The radiocarpal joint is a composite joint again, and it's an ellipsoid joint. This just relates back to the shape of the joint surfaces. So this is the region I'm talking about. So for the wrist, we have the distal radioulnar joint, which is the connection between the radius and the ulna. And then we have the radiocarpal joint, which is this area here. And these are the bones involved. Okay, so hand joints. I'm not going to go into too much detail here. The main thing I want to illustrate is that there are a lot of ligaments, especially medial carpal joint. Okay, so medial carpal joint, or you might find it called the mid-carpal joint, is a series of joints connecting the carpal bones with each other. Okay, so everything after the wrist joint is these are the carpal bones, and the connections between the carpal bones to each other, and also then to the metacarpals constitute the mediocarpal joint. So all the bones involved, pretty much all of the carpal bones and the ligaments themselves. Now the ligaments themselves, you can see, you'll be able to notice if you've had a read of this, there are palmar and there are dorsal ligaments. So palmar surface is the palm of the hand, the anterior surface, and the dorsal surface is the posterior part of the hand, okay, the back of the hand. So there are ligaments on either side to reinforce the joints. Pisiform joint, very minor joint, but you can see there are two ligaments here, the piezohamate and the piezometacarpal ligament, and it's a simple joint. The pisiform bone is a sesamoid bone. This is actually an important fact to remember. So I haven't got it on this image, but on the base of the first metacarpal bone, you'll find the pisiform bones. These are two sesamoid bones. Oh, sorry, here it is, pisiform bone, this side, my bad. Okay, the rest of the joints of the hand I've divided up into a couple of slides. So between the carpal bones and the metacarpal of the thumb has its own joint, and you can see it's a saddle joint. So this allows the opposition. Okay, the reason we have opposable thumbs is because of this joint. It allows for abduction, so movement away from the midline, adduction, adduction, movement towards the midline, opposition, which is movement away from the hand in like kind of this way, and then reposition is moving backwards. Carpometacarpal joints of the remaining digits are composite joints again. These are amphiarthroses. Okay, so the connections between the carpal bones which are present here and the metacarpals, you can't move any of those joints. They are amphiarthrosis. So very restricted movement of these joints. Then we have the metacarpophalangeal joints. So the next layer between the metacarpal bones and the proximal row of phalanges constitutes the metacarpophalangeal joints. You can see we have radial and ulnar collateral ligaments and the deep transverse metacarpal ligament. Very important to remember these names, these ligament names. And then we have the interphalangeal joints. So we have the proximal and the distal interphalangeal joints. The phalanges, sorry, with their joints. And again, we have collateral ligaments. And it's very simple, monoaxial joints. You can, perform flexion and extension in these joints. One thing I wanted to just backtrack and say is for the metacarpophalangeal joints. So these are the knuckles, where the knuckles are. You'll know you can perform this kind of movement, so this spreading of the fingers. This is why it's a biaxial joint, because you can not only perform flexion and extension, but also abduction, adduction. So this is just a quick illustration of the bones. You can see we talked about the wrist joints are here, the carpal bones are here, so that we have the metacarpal joints are here, mid-carpal joints. Then we have the first metacarpal bone, the metacarpal, and then we have the phalanges. So between the metacarpals and the phalanges, we have the joints we just mentioned, and then we have the knuckles are here. So these are the joints which can perform two axes of movement, and then the proximal and then the distal interphalangeal joints, very simple joints, simple flexion and extension. Okay, so let's talk about muscles. Sorry, I forgot to answer the question. I have a question. If you can. Okay, someone's answered it. Thank you very much. Yes, the answer is because some of these joints have variable discs. It's not always a sure thing. It's not always easy to say whether it's simple or composite. It just depends on if there's an articular disc. So you'll remember that the classification is a simple joint is one which is two bones put together, and a composite joint is three or more, or two bones, but there is an articular disc present. So in that case, yes, if there is a disc present, it's a composite joint. If there's no disc, then it's a simple joint. Okay, so in terms of muscles, so I'm not going to go into masses of detail, but to make things very simple, the 4 things you need to know about muscles, every single muscle in the human body, is number 1, the origin, so where the muscle starts from. That means which part of the bone it starts from. Number 2 is the insertion, so that means where does that muscle insert onto, which part of the bone, or is it on a different bone? So origin, insertion. Number 3 is the innervation, so the name of the nerve which supplies it. And number 4 is the function. So by function, I mean this is where you need to know your anatomical directions and terms. So flexion, extension, abduction, adduction, rotation, pronation, supination, all of these words come into play. So those are the 4 things you need to learn about every single muscle. So let's start with the shoulder. So I mentioned before, I'm just going to go up until the elbow. So the shoulder joint is reinforced by all of the muscles of the shoulder girdle. So we have rotator cuff muscles, which are visible on the posterior side of the shoulder. So these the rotator cuff muscles are the supraspinatus muscle, which is above the spine of the scapula. You can't see very clearly here, I'm sorry. The infraspinatus muscle, which is present here, which is located underneath, infraspinatus meaning underneath the spine of the scapula. The teres minor muscle, and then on the anterior side of the shoulder, which is not visible on this specimen, is the subscapularis muscle. These are the rotator cuff muscles. So, a bit of detail now. So the subscapularis muscle originates on the scapular surface of, the costal surface of the scapula. Costal, because costa refers to ribs. The Latin word for rib is costa, so costal is the descriptive word. So costal surface of the scapula. It inserts onto the lesser tubercle of the humerus and also the anterior part of the joint capsule. The innervation is the subscapular nerve, so quite easy, just the same. The nerve is named the same way as the muscle, and the function is humeral pronation. So if you imagine, humeral pronation means rotating the humerus internally. Okay, so internal rotation of the humerus is called pronation. That's the subscapularis, which we can't see here. The supraspinatus is the next one, so above the spine of the scapula, originates in the supraspinous fossa. So if you were to study the bone, you'll understand that all of the origins and insertions are basically going to be testing your knowledge of how well you know the bones and the different parts of the bones. So if you're unfamiliar with these names as I'm saying them, please go and revisit the bones. So supraspinous fossa, which is present on the posterior side of the scapula, is this area here, this small depression, and that's the origin of the supraspinatus muscle. The insertion is the greater tubercle of the humerus. Innervation is the suprascapular nerve. So this is the supraspinatus muscle, is innervated by the suprascapular nerve, and the function is humeral supination and also some abduction. Infraspinatus muscle, this big muscle we can see here, origin is the infraspinous fossa, and its insertion is also the greater tubercle of the humerus. It's also innervated by the suprascapular nerve, and its function is also humeral supination. So similar to the supraspinatus muscle, but that was the infraspinatus muscle. And then we have the teres minor muscle. So this is the origin is the lateral margin of the scapula. So the scapula, if you could see the bone, is a triangular shaped bone, and the lateral margin is here. So it originates from the lateral margin, and as you can see, you can clearly see its insertion onto the greater tubercle of humerus. Onto the greater tubercle of the humerus. But the inferior part of this greater tubercle. The teres minor muscle is innervated by the axillary nerve, so a different nerve, and its function is also humeral supination. So supination being the external rotation of the shoulder, of the arm, sorry. And then we have the teres major muscle. So you can see here the teres major muscle located underneath the teres minor muscle. Teres major originates from the inferior angle of the scapula, which is down here. This is the inferior angle, and you can see it has a similar course to the teres minor muscle, but it inserts onto the crest for the lesser tubercle. So the lesser tubercle, if you look at the lesser tubercle on an image, you'll see below it there is a ridge or a crest. This is the insertion of the teres major muscle, and its innervation is the subscapular nerve, so the same as a subscapularis muscle, and its function is adduction, adduction, extension, and humeral pronation. So different functions to the teres minor muscle, so it's very important to pay attention to this. And the final muscle to mention in this area is the deltoid muscle. So this large triangular shaped muscle here is the deltoid muscle. So the deltoid muscle has three different parts in terms of where it originates. The clavicular part, you can see, originates on the lateral third of the clavicle. The acromion part is originating from the acromion, which is a process of the scapula. And on the posterior side, we have the spinal part, which is from the spine of the scapula. These are the three origins of the muscle. You need to know all three. The fibers will all converge and will insert as one tendon onto the deltoid tuberosity of the humerus, which is located on the lateral side, roughly a third of the distance down from the humeral head. The innervation is the axillary nerve, same as the teres minor axillary nerve, and the function is abduction and anteflexion, but also some dorsiflexion as well. So posterior movement, anterior movement of the arm, and then abduction, so movement away from the midline. Okay, so then the next few muscles to mention are the arm muscles. So these are, again, quite straightforward. There are only a few, thankfully, to learn. We have two muscles on the anterior side, and we have three muscles on the anterior side and two muscles on the posterior side. So only 5 muscles. It's very, very straightforward. So first of all, we have on the anterior side, oops, my bad. Sorry, just bear with me. Sorry about this. Okay, I'm just going to enlarge my screen and just explain whilst I get my presentation back. It's just glitching out a bit. So on the anterior side, we have the brachial muscle, or the brachialis. We have the biceps brachii, and we have the coracobrachialis. On the posterior side, there are 2 muscles, so the triceps brachii and the anconeus muscle. On the anterior side, first of all, the brachialis muscle originates on the body of the humerus on the anterior side, so roughly just beneath the shoulder joint. On the anterior side of the humerus, we have the origin of the brachialis muscle, and the insertion is onto the ulnar tuberosity. The innervation is the musculocutaneous nerve. This is the nerve, just incidentally, which innervates all of the muscles of the anterior arm, so all 3 muscles. And the function of the brachialis muscle, very simple, it's flexion of the elbow. Then we have the coracobrachialis, which is a very short muscle. This origin is on the coracoid process of the scapula, and the insertion is onto the body of the humerus, roughly a third of the distance down from the shoulder joint on the medial side. And its innervation is also the musculocutaneous nerve. The musculocutaneous nerve actually pierces through this muscle. When you look at it on atlases, you'll see what I mean. And the function is adduction, so bringing the arm back towards the body, and also anteflexion in the shoulder joint. And that means movement of the arm and raising it upwards. That's anteflexion. And finally, the biceps brachii. So the biceps brachii originates, actually has 2 origins. We have a long head and a short head. As the name suggests, biceps, bi meaning 2, ceps referring to heads. So there are 2 heads of the biceps muscle. Sorry, just bear with me, almost here. So the caput longum is the long head of the biceps muscle. and we can see this quite nicely here. This is the long head. Now it doesn't look like the long head, but if you remember when I discussed the shoulder joint, I explained that the long head of the biceps brachii muscle actually passes through this, which is the shoulder joint. Passes through it, and its true origin is not here, it's actually over here. So it passes from the supraglenoid tubercle, which is on the scapula, travels through the joint capsule itself. This is the tendon, and it emerges here. The short head is located here, and the short head originates from the coracoid process of the scapula. So you can see the coracoid process here. The two heads will unite roughly halfway down the arm, and at which point they will, you can see, fuse together, and the muscle itself, strong inserting tendon, inserts laterally. This is not the insertion. This thing here is not the insertion. This is the tendon here. The muscle tendon is seen here. And this inserts onto the radial tuberosity, so the lateral bone, the radius. Innervation is also the musculocutaneous nerve, and the function, as I'm sure is quite straightforward, is antebrachial flexion, so flexion in the elbow joint, and also pronation and adduction. So this is everything you need to know for the biceps and the anterior group of muscles. Now the posterior group of muscles. So I apologize for the image quality. I can see it's quite poor, but only two muscles to learn: the triceps and the anconeus. Triceps meaning three heads. We have a long head, we have a short head, and we have a medial head. So long head, a lateral head, and a medial head. Apologies. So we can see the long head is located here. This is the long head. This is the, ignore this, these two schemes. These are the anterior parts of the arm. This is the posterior part. So the long head is present here. And then we have the medial and lateral heads located beneath. So the long head originates from the infraglenoid tubercle of the scapula. The lateral head originates from the body of the humerus, and the medial head also from the body of the humerus. But the way you have to describe the origins are in relation to the radial nerve, or the groove for the radial nerve. So the groove for the radial nerve is an anatomical landmark, a bony landmark on the humerus, and in the groove, as the name would suggest, in the groove we have the radial nerve. So the lateral head of the triceps muscle originates proximal, so proximal to the groove, and the medial head originates distal to the groove. And all three heads will unite, as you can see, and they will insert into the olecranon ulnae. This is the bony process of the humerus, and onto the ulna itself. Innervation is the radial nerve, as you can clearly see here, and the functions. The long head of the triceps actually participates in arm adduction, so bringing the arm back to the anatomical position. So that's actually the caput longum, which contributes to that, and the other two heads also facilitate that as well, to a lesser extent. And the last muscle is sometimes referred to as the fourth head of the triceps, although it's a separate muscle. It's called the anconeus muscle. Origin is the lateral epicondyle of the humerus. The insertion is exactly the same as the triceps, so it's the olecranon ulnae. Innervation is the same, the radial nerve, and the function is the extension in the elbow joint. And extension function is the extension in the elbow joint. Okay, so from me, that's where I'm kind of going to end. I'm going to teres major is not part of the rotator cuff muscles. Sorry, I'm just answering the questions. And yeah, this stream will be uploaded on this channel, as I mentioned before. Okay, so one last thing is, if you guys enjoyed this, if you didn't enjoy it, I would love to hear. If you could provide some feedback, I would be really grateful. The link is in the description for this video. And to make things easier, I actually do have a, yes, I do. I have a QR code. Please scan it. My name is Deelan Vadher. It's if you need the spelling, it's in the description for this video. We will upload this later on. The next video will be next week. We're going to have weekly anatomy videos. So all the information will be posted in the Anatomy Atlas Facebook group and the Freshers group. But as time goes on, we'll be using the Freshers group less and less for Invent. And if it's related to anatomy, it will just be in the Anatomy Atlas group. So yeah, if you have any questions related to anatomy in general, feel free to ask. I forgot to properly introduce myself. Apologies about that. I'm sure you guys already know who I am. I'm president of the student organization. But from an anatomy point of view, I'm a teaching assistant at the department. This is a position I've had for the last 2-3 years. So you may see me around one of your classes this semester. So yeah, if you have any questions at all, ask me here, ask us on Facebook, or kind of you can just mention it on the feedback form. So yeah, please fill that in. I really appreciate it. Thank you for your time. Enjoy the rest of your day, your weekend. And yeah, I hope anatomy goes well. I think I'll be doing at least one more lecture this semester. So I'll see I'll see you guys then. Okay, anyway, thank you very much. Take care.